population live in rural areas. The literacy rate was 91% fixed among adults aged above 15. The total fertility rate was 2.5 children per woman, and the under 5 mortality rate was 17 per 1,000 live births. The median age of first marriage of women nationally was 21.7 years old, and about 30% of total population was at the risk of malaria in the year of 2011. So looking deeper into the background, in the year of 1967, the famous novelist Garcia Marquez wrote this novel named 100 Years of Solitude, talking about neglected Latin America under the Spanish colonialism. Even today, colonialism does no longer exist. Malaria still exists on this continent. About 75% of malaria infections in Peru, in the whole Latin America, was caused by P5X, a species that was less fatal compared to Plasmodium falciparum, but it was under study overall and caused significant morbidity, especially among children and pregnant women. And in the Amazon region of Colorado, this region is where about 60% of malaria infections occur in Peru. So in this map, we can see the distribution of Plasmodium species in Peru. The red dot is the city where I went last summer, in Iquitos region of Colorado. And in this legend, we can see the darker color represents higher risk of the species of malaria. And here is a chart of reported number of cases of malaria in the Laredo province. Since the year of 1997, Peru, the Peruvian government implemented this national malaria program, and therefore the case dropped within the next few years. But it came up again since the year 2001 because there were floods and other environmental modifications. And it dropped again since the year 2005 because National Institute of Health, they implemented a lot of health and malaria programs, and UNICEF participated in a lot of this surveillance programs, and therefore we can see a drop here. And increased again in research again in the year of 2012. So another very interesting fact about malaria transmission in Peru is the malaria migration, especially in the region of Amazon. Due to the rapid population growth and the development and transportation, it enables people to travel to work in a daily or weekly circulation of labor migration. And this migration mainly include agricultural industry, logging and fishing, and those working adults travel to the logging areas, fields, and conduct their outdoor activities. Coincidentally, this working areas coincides with the mosquito and knockling darting these fighting hours when these migrant laborers conduct their outdoor activities in the morning and towards down. And this newly open agricultural areas dramatically increase the knocklings breeding sites. And this migrant workers, they became human reservoir once they got infected with malaria, and when they return home where there are other family members living in the household, the in-home malaria transmission risk was highly increased. Another fact about the Peruvian Amazon was early marriage. According to the Peruvian Civil Code, no man or woman is allowed to get married before the age of 18. However, in the whole Peru, about 40% of women were married before the age of 18, and about half of this marriage happened in rural areas. According to the previous literature, there are 4 main reasons of early marriage in the developing world: limited employment, lack of education, urbanization and lack of health infrastructure. Because employment is a financial incentive that family and their daughter will like to prolong this economic productive period. They can stay single and work. And also employment would expose females to Western values and ideology that they would like to delay marriage timing. And education is a very important factor, because also like employment education exposes women to Western ideas, adopt new ideas and values. But in the developing world, when an individual completes its high school education, the age to complete high school education was generally 16 to 18 years old. Therefore, those who completed high school education are unlikely or less likely to enter early marriage. And urbanization, the reason for urbanization was, well, urban and rural, the difference was mainly the demand for farming labor. In rural areas, there were abundant farming fields but scarce labor forces. So those young couples in the rural areas were therefore encouraged to start the next generation, start a new life circle, and therefore the early fertility or early marriage happens a lot in the rural areas. And the health infrastructure played an important role, especially in reproductive health and family planning methods for the females. So therefore, early marriage happened a lot in the developing countries where health infrastructure is not well established. And all those I talked about is just literature on the paper, but we need to step into the field and see what's really going on there. So last year I went to the Peruvian Amazon. I went to the city of Iquitos, and we conducted mosquito collection mainly in the two study sites. One is the Rio Napo, along this river up to Ecuador, and this highway road connects. Here's the town of Mazan and the city of Iquitos. So I conducted mosquito collection from May to June, about 2 months collection, and since July to August, I went to our lab in Iquitos and conducted immunology tests on this mosquito sample. But more than that, this whole field work was very interesting. In the morning, we took a boat to the Amazon River up to those communities, and we went to this community where there's about 40 households in each community. The houses were built with wood and straw, and we stay in one of these households and collect mosquitoes in the night, using ourselves as human bait to roll up ants and to attract mosquitoes onto our leg, and then use a tube to suck absorb the mosquito into the tube, and then blow them into the box there. And it's like 8 hours of living night work, because the mosquito were most active during nighttime. These are the river trip we conducted along the Rio Napo. We also conducted road trips. We walked along those jungles. We walked through these jungles actually, and we collect mosquitoes during nighttime, or have a Coca-Cola in the only community where electricity was available and there's a freezer, and enjoy the beautiful sunset at night. And most importantly, talking to these early married families in this community. In this picture, the father was a migrant laborer who conducted weekly outdoor activities into the forest as a logger, and the mother who was married at the age of 16, and now they have 2 children. One is 5-year-old, the other is 4-year-old. Sorry, the other is 4-year-old, and the two children were both infected with malaria in the year of 2010. So then I decided to come back to the U.S., come back to Duke, and look into this database to see what really happened during the past 4 years to these people. I decided to describe child malaria characteristics in these communities and explore the hypothesis. Our mother's early to explore the hypothesis, our mother's early age of marriage maternal younger age of birth, and family members' involvement in labor migration associated with malaria risk for these children. And so I designed this study method. This study was actually built upon the infrastructure of an existing longitudinal study conducted by the Johns Hopkins University, their public health school. It lasted since 2009 till last year. About a total number of 18 communities was investigated along the Rio Napo and the Iquitos Mazan Road. And the total population we looked at was 852 children. So the recruiting strategy was we went to those communities, and in each community there are multiple households. In each household there could be one or multiple mother. If there is only one mother, she's the female head of the family, and if there's a second mother, she could possibly be the sister of the female head or the daughter of the female head who has already established a family and have her own child, meaning there could be 3 generations living in the same household. And after we identified the mothers, we could identify all her children in their database. To be finally included in the study, the children had to be under 18 years old, had to be unmarried, and had to be living in the household when the baseline survey or follow-up surveys were administered. And those children characteristics, about 1/3 of children were aged under 5, and 44% of the children were girls. And we also looked into their using of treated bed nets. So this is a picture of a real treated bed net on the UNDP, UN Development Program, their display. And here's a picture of a girl sitting in her bed net in the Peruvian Amazon. The difference was invisible, but it was enormous. Actually, her net was not treated at all. Fact about this bed nets, only about 1/3 of children were using bed net at our baseline survey, and most of the children were from the river communities. My personal explanation for the riverine community, a large distribution of children using bed net was it was much easier for shipping the bed nets along the river, because if you're living in the rural communities, you're living in the jungles, you're entirely using human forces to carry your necessities into your household, and therefore it was much easier to get a bed net along the river communities. So we also look at multi-level covariates. We look at mother's education level. We also look at mother's malaria history. Has the mother ever been diagnosed with malaria? Previous literature believed that mother's maternal malaria history might give her better experience when she's having a child who's infected with malaria. But genetically, some researchers believe a pregnant mother, which she's infected with malaria during pregnancy, her baby may lack immunity and antibody towards the malaria infection. At the family level, we look at father's age of marriage, father's education, father's occupation, and extended family. This means if a child is living with an extended family member, for example, grandparents, granduncle, grandaunt. So in this picture is an example. The 2 children, their parents are migrant laborers, and they conducted weekly circulation of logging, and these 2 children were living with their grandparents. And we also look at the number of children living with mother, because we believe this is a good indicator as mother's experience in childbearing. And we also looked into socioeconomic status. It's a principal component analysis, looking at their house building materials, water supplies, resources, and sanitation facilities. We look at the community level variables, including the community size, and if the community is located along the Iquitos Mazan Road, or is it along the River Napo. And we also look at if there's a health posts available in the community. So again, our primary variables of interest are mother's maternal age and marriage. The cutoff was 18 years old and 21-year-old, and maternal age of birth and labor migration. And we categorized the labor migration into no one in the family was migrant laborers, and only mother was the labor migrant, and other family members except mother was migrating, and mother and other family members are all all traveling. Because we believe mother has the closest relationship in childbearing, and if she's traveling and at the same time she's taking care of the child, the risk might be different, so we categorize it into this. And our outcome was the count of malaria episodes, and adjusted for time of exposure. We conducted this data analysis in multi-level Poisson regression tests. So here's the result. This chart here is the distribution of number of cases over time. Although there's large fluctuation, but we can see the trend overall is declining. And at the maternal level, this is a descriptive summary statistic. The average age of marriage was 18.8-year-old, and the average age of childbirth was 27.2 years old. This age was actually much older than the age of marriage, because we did not only look into the first childbirth. We look at the mothers, all her children, the age at childbirth of each of her child. And half of this marriage happened between 18 years old, but previously in the literature review we discussed the national level was 40%. 40% of the marriage nationally happened before the age of 18. And about 15% of the birth happened before mother's age of 18. And the majority of mothers only attended primary school, and most of the mothers had malaria before. At the family level, about 10% of the children lived with a migrant mother, and only the mother was traveling. About 15% of the children lived with a migrant mother and also other family members traveling. The majority of the fathers worked in agriculture, and 21% of the children lived with an extended family member. About 11 communities were located along the road, and 7 were located along the river. Only there were 12 communities had a health post, but 6 did not. So here is the multivariate regression result. From here we can see, compared to here, maternal age of marriage, compared to those mothers who married after the who are married after the age of 20, who were married before the age of 18 had a incident rates ratio of 2.19, and those who were married between 18-year-old and 20-year-old had an incident rates ratio of 2.01. And also we found the association between maternal age at childbirth compared to those mothers who had a child after the age of 34. Those who had a child before the age of 18 had an incident rates ratio of 2.13. And we also found a significant association between family members' involvement in labor migration. Those family members who, none of the family members ever traveled was used as a reference group, and those whose mother was the only one traveling in the family, the children had an incidence rates ratio of 5.35, and those whose mothers and other family members are simultaneously traveling, the children had an incidence rates ratio of 6.99 compared to those family members who never traveled. And we also found other risk factors that are significantly associated with our outcome. Mother's education level. those who never attended school had an incidence rate ratio of 1.91 compared to those who had secondary high school education and above. And in the father's occupation, those who were occupied in agriculture had an incidence rate ratio of 6.87 compared to those unemployed fathers. To our surprise, we actually believe that, in the literature, we believe that those logger fathers may have the highest risk compared to other occupation types. But here in the study, we found agriculture was actually the biggest risk group, because in most of the study sites, there's the deforestation was very obvious in our study sites, and we believe, therefore, especially those farmers need to walk through the jungles to get to their working sites, and we believe they're walking through the deforested areas, and that would increase the risk. And interestingly, we found there's an active association between the community locations with our outcome. Those in the rural communities, the child malaria incidence ratio was much lower compared to the river communities. So, to reach our conclusion, this study provided a new approach to malaria control and linking family health with early marriage, a human rights issue. But there is absolutely limitations. For example, external validity, because we only look at the Peruvian Amazon. If we wanted to apply the early marriage theory to other regions in the world, we need to look into different reasons of different settings. And other important variable that could be included was the parity of the children, meaning the child birth order. So if that's the eldest child, he or she might get more attention or care from the parents, and that might also apply to the youngest child, who might actually get care and attention from the elder siblings. And we may also want to look at mother's current age, because even though the mother was married young, now she's not younger anymore, and she might get more experience in childbearing. So we may need to look at that data in the future research. So the policy implication was, the recommendations was to enforce legislation and to educate the girls, families, and the communities about marriage timing and human rights and female rights, and also to empower the women with employment and the trade skills, because we can see a lot of mothers, they were migrant workers, and they're traveling, their labor migration actually increased the malaria risk for their children. And if they can get technique training, for example, cooking and sewing, and weavery industry, they may not need to travel to work in the forest and come back and bring malaria to the children. And as we discussed previously, employment would also delay the time of marriage, because it provides women with economic independence and new ideas, new values. So, acknowledgement. I would like to thank the Global Health Institute for providing me the great education and fieldwork opportunities, and Johns Hopkins University, Bloomberg School of Public Health. This research was actually built on their longitudinal study, and Prisma was the local lab in the city of Iquitos, where I worked on the ELISA immunology test. And I would like to thank Dr. Pan, Dr. Masako, and Dr. Boyd. They're my very gifted this committee. And Justin Lana, a previous Duke Global Health Master student, my fieldwork teammate, without whom I would otherwise be alone in a foreign country. But mostly I would like to thank all those early married mothers and children in the Peruvian Amazon. Without them, this research wouldn't be possible. And their experience and their story, the story that they told me to trust my gut, to work not only for any project, but also to work for what I believe in. So.